Welcome to my dear friend of many decades, Professor Abe Fingerhut. Professor Fingerhut has been the chief of surgery at Poissy in France for many, many years. He's been a former co-editor-in-chief of World Journal of Surgery. He's past president of the European Association of Endoscopic Surgeons and the World Congress of Endoscopic Surgery, amongst other functions. And very importantly, Professor Fingerhut is an honorary fellow of the American College of Surgeons. Welcome, Abe.
Well, thank you, Steve. That's a great introduction, and I'm very proud and happy to be part of this presentation.
So, Abe, you've published a couple of recent studies related to COVID-19 in Annals of Surgery, and certainly with all of your editorial background, you're well versed in the current literature. There's a big ongoing debate about laparoscopy and other minimally invasive techniques versus laparotomy. So let's start out the paper that you published with the EAS group and talk about the potential issues of virus particles and a smoke plume and where that positions us for the type of access for surgery in two groups of patients. Firstly, patients who are not thought or known to be COVID positive, and secondly, patients who are definitely COVID positive.
Okay, yeah, thank you for that question. Very, very up to date and very timely. First of all, I think we have to state once again that unfortunately, many of the learned societies in the beginning of the COVID pandemic made some very strong suggestions that laparoscopy might be dangerous because of the current virus situation, which led us to our first paper with Zheng, Professor Zheng from Shanghai, stating that, yes, this has been known for many years that the smoke plume or the creation of coagulation of tissues, dissection of tissues in a patient that had a viral infection might be responsible for creating an aerosol which contains viruses. At that time, we didn't know that there was any viruses in, although papers have led to believe that this was the case for HE, for hepatitis B, and for the papillomatosis virus. And so it was very, very important that with Professor Zheng that we wrote this paper, well, now it's written, trying to make sure that people understand that if this risk is so important, and it certainly is of concern, there are, let's say, techniques that we have to adhere to make sure that there is no problem with laparoscopy, specifically in this situation. So this leads me to say that laparoscopy is working in a contained cavity. We have it closed. It's different from laparotomy. Laparotomy, we're open to the atmosphere of the operating room. We have the same problems with smoke. There's no difference in the smoke creation between laparoscopy and laparotomy. We have the possibility, because of that closed cavity, to contain it and to eliminate it without it being diffused into the atmosphere of the operating room, which we don't have in laparotomy. So this is really something that we have to outline. And that was the purpose of that paper, is to raise the awareness to the surgical community that that is really one of the advantages of laparoscopy, and especially in this era. Now, it's not taking a then that the second paper was on the filtration, one of the many means of making sure that in the elimination of the CO2 for desulfation, for specimen retrieval, for conversion, whatever, that we should be sure that the particles are filtered out and not just left to diffuse wherever. So I think that was the basis of those two papers, yes.
So if I understand correctly, you advocate that it is safe, or at least potentially safe if done the right way, to proceed with a minimally invasive approach, whether the patient is COVID positive or negative.
Okay, yes, I am saying that. That's a general statement, but there are caveats. And one of the main caveats is the fact that we have to make sure that the pulmonary function is adequate to perform laparoscopy. We all know that the COVID virus has an affinity for the lungs. Many people have, since the beginning of the epidemic or the pandemic, described 4 phases actually, of the rising phase, the plateau phase, and then the infiltration phase. Now, if we have a patient that's COVID negative, as you alluded to, and proven so, I think I can say that most everybody would agree that there should not be a big problem. If the patient is potentially infected or potentially or proven to be, we have to be very careful about the pulmonary function. And there, a CT scan, although there are people that are for, people that are against, perhaps even spirometric. There's now Chinese publications coming out that we have to do not only a CT scan, but the spirometry parameters have to be taken into account to make sure that we're not in that phase 3 where we have bilateral infiltration. And then if that is the case, laparoscopy should still be safe. But if it's not, then we have another problem.
So what are some of the caveats for laparoscopy to be safe?
To begin with, let's go back to the basics. I think we have to make sure that our trocars are inserted without any air leaking around the incision. That means real airtight incisions of the skin, making sure that the trocars are working correctly, make sure that the valve is working correctly, that there's no unintentional leak, especially when we're putting the instruments in and out. This is something also that's very important. I think it's been shown, even though it's all only experimental, that we should be very careful when we exchange instruments, that we do it slowly and without let's say, shaky movements, because these movements may be a source of air leakage through the valve as we exchange the instruments. So that's for the trocars. The trocars, only one trocar should be used for the connection to the evacuation system. There is some debate also about the two-way valves, whether they're good, whether they're bad. I'm not so sure that there's very much evidence out to prove which way we should go on that. Blood on instruments should be cleaned. We know that blood can contain the viruses as well. It's something that we all know, but probably have never, or a little bit, let's say, neglected before the COVID epidemic has really put our minds to this. And then the other problem is the elimination that we've already talked about.
And then the other question is there any value to disposable instruments, both disposable trocars and the working instruments, or is it fine as long as you say the blood is off and the instruments are re-sterilized?
Good question. I'm not sure I have an answer like that. I would say that disposable are probably safer in the fact that they should theoretically be sterile when we use them for the first time. During the operation, of course, it's up to the scrub nurse to make sure that they stay sterile, they stay clean, and perhaps using a solution during the operation every time an instrument comes out would be a solution. I'm not aware of any literature on that for the moment, at least.
Okay, thanks. Any tips on the type of pressure to use with pneumoperitoneum, filters, a couple of different topics, filters, whether there's any value in electrostatics? I've heard some rumblings about that, similar to the HEPA filters that are used industrially, or on desufflation. Any sort of technical tips in those areas, filters and pneumoperitoneal pressure, desufflation? Okay,
let's talk about the pressure first. It seems logical, although we don't have any, 100% scientific, grade A scientific proof that it would be advisable to use the lowest pressure possible in order not to compromise the operation for 2 reasons. First of all, and most importantly, I think, would be the effect on the diaphragm. We do have to preserve the diaphragmatic function in these patients because of the risk of the pulmonary complications that we're aware of. and then the other would be theoretically to decrease the possibility of diffusion. That's for the pressure. For the filtration, the electrostatic filter was chosen in our paper because it's readily available. It's the valve that the anesthesiologists use. So this is the reason why we chose it. I'm not so sure that there's any steadfast evidence for or against that type of valve in particular, but it works. We know that it works, and it works. It filtrates it more than 99% of particles of the size of the COVID virus.
And another area that's related is negative pressure operating. Although it wasn't the theme of your two publications, I'm curious if you think that adds any value for safety of the team.
I am aware of the fact that people are interested in that and people are recommending that. I'm not aware of any evidence that's been where it's been shown to have any effect in the current pandemic, but it certainly seems logical.
And then one last question, although it wasn't one of your manuscripts, I know you're familiar with it, from Lei and colleagues from China, who published what I think is the first series of surgical patients in the COVID-19 era. And if you could give us your reflections on how that paper should guide us.
Yeah, it's a very interesting paper. And I must thank you because I read that paper because you pointed it out in Facebook a couple of hours ago. It's a study on 34 patients, and there were various procedures being performed, some of them orthopedic procedures. But what's most interesting, as far as I'm concerned, is that all of these patients required ICU care after their operation. All of the patients developed post-operative pneumonia. And 7 of these patients died. Only 2 of the patients were over 77. One was 77, one was 83. All these operations were considered level 3 in difficulty. There was a there was a Whipple, there was a vasectomy, there was quite a array of interesting operations. All of these patients had at least one comorbidity. That's something that we have to note. So what is important is that 7 of these patients were operated on or underwent laparoscopy. None of these patients died. All survived. The only patient that had a thoracoscopic procedure, one of the 3 patients that had a thoracoscopic procedure died, and the other patients that died all had laparotomy. So I think this is something really, and the procedures that were performed laparoscopically were, so there was 2 appendectomies, 3 segmental colectomies, and 1 radical gastrectomy. So these are major procedures as well, and they went very well laparoscopically.
Well, thank you very much, Abe, for your insights and wisdom, and for the few minutes sharing your thoughts with us in this ACS COVID-19 interview. I wish you and Marie and the rest of your family sustained health and safety through the pandemic. I look forward to seeing you in person when after it ends.
Yeah, okay. Same to you, Steve. I'm very, very happy and honored to be part of this, and I thank you for the invitation.